So I have the pleasure of introducing Kiffin here, correct? Did I say it right? Okay. Kiffin and I have known each other for quite some time, and she is a nurse practitioner for neurosurgery, endovascular neurosurgery at Advocate Aurora Health in Chicago. She will be speaking to you on, I think it's actually pediatric stroke, not posterior stroke. So programs haven't been updated since that changed, but they have a really good experience. So I'm really excited to hear what she has to say. I know pediatric stroke doesn't happen often, but when it does, we definitely have an opportunity to make a very positive impact in the lives of these kiddos. So I'm excited to see what she has to say, and I will welcome her to the stage.
Okay. All right. Hi, everybody. Thanks for having me. As Wendy said, we've been friends for a long time, and my name is Kiffin Kier. I'm from the Chicago area, so loving the weather down here. And yeah, I was going to talk on posterior strokes, and then Wendy and I started chatting, and she's like, "What about the peds stuff you've been doing? Let's hear about that." And I was like, "Okay." So that's me preparing a pediatric stroke team. So before I get started, just really quickly, just to kind of get a consensus in the room, how many of you are peds nurses in here or work in the pediatric space? All right. Oh, yes. Yeah, right. Okay. And that's just it. Is full disclosure, me either, really. So I'm an adult acute care NP. That's my training by background. But many of us oftentimes say, well, why do we need to know about this? Why do we need to get involved? And because many of us are involved, we need to get involved in our PEDS programs. How many of you work at a hospital that has a children's hospital attached to it? All right, look at all the hands in the room. And this is why you need to be engaged in a PEDS program and a PEDS process, is because they really need us as the experts that have spent many years creating adult processes and adult teams. And how do we create a PEDS process and a PEDS team? So I have no disclosures except to disclose I'm not a PEDS nurse. I've learned a lot in the neurosurgery, neuroendovascular space. You can't help but to take care of PEDS and kids when they come in through your children's hospitals. It's inevitable that we are going to touch base with them. So just really briefly, I'm going to talk a little bit about the incidence of pediatric stroke. It's rare, right? We don't see a lot of it, but it doesn't mean we shouldn't have a process in place to deal with it when it's occurring in front of us. So 1.2 to 13 per 100,000 cases in kids under 18 years of age. One of the biggest reasons that we launched in this journey where I work is because it is frequently a misdiagnosis. We just completely miss this. It's not on our radar. Kids present differently. We have a low level of suspicion. They have very subtle symptoms. They oftentimes present as mimics. And we have then a delay in diagnosis. So oftentimes this is hours to even weeks to months after the fact before we really figure out, oh gosh, that kid that we treated had a stroke event. We thought it was X, Y, and Z. It's more common in boys in the African-American community. And really we see it in our pre-existing pediatric patients who have congenital heart conditions and our sicklers, right? So really understanding if you're at a children's hospital that is seeing a lot of congenital heart or a lot of sickle cell patients, you really are primed up to be seeing these types of patients in your emergency rooms and in your units. So kids also present differently to us. Their clinical manifestations of stroke are quite different than the adult population. So this isn't a one size fits all. It's not like you can look at a kid and say, oh, they're going to present just like our adult population presents to us. They don't, as a matter of fact. They oftentimes present with mimics and kind of these subtle, less focal symptoms, which make it difficult at onset for us to really recognize a ped stroke. They have different risk factors as well. So I've listed some of the more common. We see rheumatologic disease, oncologic malignancies, or hematologic problems such as sickle cell, of course, our congenital hearts. If you work in a kid's pediatric trauma center, you're going to see strokes associated with pediatric trauma. Again, that's an inevitable potential miss that we always want to have that on our radar. You have peds trauma. I can't tell you how many patients in the last couple of years I've seen who have flipped over their bicycles or been in some sort of sports injury with dissected carotid or vertebral arteries that end up on our tables. So really important we have this at the forefront of our mind. Infection, of course, our kids get infected with meningitis, COVID, different types of infectious processes, and vasculopathy. So I will just say some of the more common things that we see are cavernous malformations, bleeds from CAV-MALs. We see arterial venous fistulas, arterial venous malformations. And of course, that is a young patient population to begin with, right? When we see bleeds come in with AVMs or fistulas, oftentimes that's not an older adult pathologic disorder. We see it a lot in our younger patient population, and moya syndrome. So we see a lot of this in our pediatric group. So something to keep in mind. And of course, we see intoxication, drug use, pregnancy, but I'll say oftentimes, many of us, if we see that 16, 17, 18-year-old that comes in, sometimes we see these symptoms and say, oh, have they been doing drugs? Oh, have they been drinking alcohol? And rather than walking the stroke pathway, we are making some assumptions that if we don't have the right time to pull triggers on when we should be having a stroke alert, we can miss those diagnoses. So for this very reason, we have to ask ourselves, why do we need a separate pediatric stroke team? Do we need one? And the answer is yes. If you're seeing peds stroke patients in your hospital, you should have a completely separate process and team related to this. Pediatric patients have very specialized needs. We talked about a congenital heart patient. Our adult patients, for instance, what's our common risk factors? Diabetes, hypertension, hyperlipidemia, smoking, poor lifestyle choices, right? Well, it's not our kids. Our kids aren't coming in with high cholesterol and some have diabetes, of course, but they don't have high cholesterol. They're not smoking. They have congenital heart conditions. They have hypercoagulable conditions. So they have very specialized needs that we're going to need a team to be dealing with those specialized components of our peds patients. It's a misdiagnosis. We don't want to miss any diagnosis. So this was actually, again, the impetus behind our organization's reason for going down this pathway to say, why did we miss these? We actually had a series, full disclosure series of missed stroke diagnosis and a set of patients that really prompted us to do a large quality review and said, we don't have a process in place. We miss these kids because we don't have a trigger. We don't have a trigger for a stroke alert. And everybody was hesitant to pull that trigger to say, I'm going to call the stroke alert and get a team to the bedside. Then we realized, well, we don't even have that team. So really the misdiagnoses was what really prompted this. You need communication channels, right? You need to reach out to many people when you talk about pediatric stroke, because there's going to be that fine line, where you go from peds to, we need the adult team to step in too. We know we're going to need some cross coverage. So communication is important. It's very resource intensive. There's a lot of people that need to get involved. And if you're at a children's hospital providing specialty care, you are definitely 100% more likely to see these patients than any other hospital group. So if you have a children's hospital connected with you, really, I would hope you'd consider having a separate ped stroke team. So who are we? Who do I work with? Well, I work with Advocate Children's Hospital, which is part of the Chicagoland Children's Health Alliance. And we partner with University of Chicago Children's Comer and North Shore Children's Hospital. So we actually have 2 children's hospital in our system. So we're 434 beds, pediatric beds, with 27 medical and surgical specialties. So the 2 hospitals, our 2 children's hospitals, are connected to level 1 traumas. Both are level pediatric trauma and adult level 1 traumas. Both are comprehensive stroke centers. So we do have a lot of resources in the building. We decided we've got the resources, the capability of taking care of these kids. We just needed to put it together. We just needed to collaborate and coordinate how we were coming together. So what were some of the questions we asked ourselves as we really launched our idea to begin the journey? Well, what was actually our pediatric stroke alert volume? And I'll show you some data in a little bit. And we've come a long way. Did we have pediatric neurology, vascular neurology? Who were our services, right? Neuroendovascular, neurosurgical services. Are they in the building? Are they willing to partner with us? Do they currently partner with us or not at all? Are we at completely separate tables? Who are all the key stakeholders that would need to get involved in this process? Do we have buy-in? and who are the champions. Every step of the way, you will need a champion. But I would tell you in this process, I would absolutely encourage a pediatric champion to be leading the charge. You 100% need that in collaboration with all of the other stakeholders. But at the very least, that's a person that's going to launch us. It's going to lead the group. They're going to be the director of the ship, if you will, making sure the pieces and components stay together. Do we have the critical care units and teams to take care of the patient, right? Are you at a hospital where you can keep this patient there? Or are you at a hospital where you actually are seeing a lot of peds, but you need to transfer them out? And that's something we considered as well. I'll show you in a second a case of a patient where we coordinated putting together our pediatric program, where not only we could take care of the patient at the Children's Hospital primary hub site, but where our spoke centers were receiving patients, and how did we partner with them so they knew how to get them transferred to us in a timely manner. Is this initiative supported by administration? If you don't have that, we don't have a program. We need executive leaders at the table to say, I fully support this. What do you need? Okay. And then, as we just heard, did you do your homework? Do we have a good lit search that supports all the initiatives, the management of these patients? What are our guidelines? Are there guidelines? And there are guidelines around pediatric neonate stroke. So understanding that and putting that in place is really important. So where did we start? Our starting point considerations were to confirm our approval from executive leaders. Got to check that box. We got that approval. We created a stakeholders group. We designed our workflow and our algorithm. It didn't exist. We didn't have a workflow and algorithm by which our PEDS patients followed when they entered our doors. Then we created inclusion exclusion criteria. And oftentimes when we talk about inclusion exclusion, everybody automatically thinks, oh, about thrombolytic therapy, not talking about thrombolytic therapy. Yeah, we need that. And we do have that in place. But inclusion and exclusion on when do you call the stroke alert? When do you initiate? Because that is really a decision point that is not well delineated in the pediatric stroke population. And especially when they present to emergency rooms. How many of you are here in the emergency room? Handful. You don't know when to pull the trigger. Oh, is this somebody that they have a headache? Oh, they came in with seizures. Oh, they came in with a speech issue. So we don't have the criteria to say, we empower you to pull the trigger on a pediatric stroke alert process. Let's get it going. Select your neurological assessment tool so that it fits the needs of a pediatric patient. What's your education and training and rollout going to look like? How are you going to evaluate and have continued oversight of your pediatric process and and they shouldn't be rolled into one. I would encourage us to be looking at our pediatric stroke population in a different forum from our adult population, right? They have different needs. We have different stakeholders. We're going to look at data a little bit differently. And then data. How are we going to have ongoing review of our benchmarks and good outcomes? So this is just one example of a patient. I'm going to go through this quick because I don't want to run out of time. And I do that a lot when I speak. So keep me honest. But we had one of our spoke primary stroke center sites receives patients, including pediatric patients. It came in as a stroke alert activation at 13:03. Good news was that this patient actually had a right hemiparesis, did have kind of a presentation that looked really stroke-like, had neglect, a gaze, their CT head was negative. The CTA was concerning for distal left MCA occlusion. They were not a candidate for IV Ultiplace. They were outside that window. And so I'm just kind of showing a process by which we use a program called Join. It's a communication tool that we actually communicate with our spoke sites at our comprehensives and with our pediatric team at our primary, at our hub. And so we launch on there, and I know you can't see it, but it does say LGH Ped Stroke Group. So what they can do is actually launch a case on Join to say, hey, we've got a ped stroke alert in the ER. And that gets that Join notification comes from Good Samaritan, that hospital. It gets viewed on our Viz platform. So we can launch our Viz imaging picture directly into our Join chat. where our pediatric stroke alert team can see that notification from our spoke site. We have worked with our PEDS transport group that has our algorithm on what their role is in going to pick up that patient and to bring them to our hub site. They contact our patient command center, who knows that this is a direct to IR with Dr. Lopez at our comprehensive in our children's hospital. So in this particular case, you can see we had activation of this 3-year-old whose last known well was 12 noon. Activation was at 13:03. And actually, I said that they weren't a candidate for IV Alteplase because they were outside the window. I actually think that they had not determined that they felt comfortable giving to this 3-year-old. But door time at the comprehensive center was 14:19. We had her in the lab at 14:21, puncture at 14:35, thrombectomy completed and transferred to the PICU stable, and then workup progressed by the pediatric team. So she actually was discharged with an NIH of 0 with a cardioembolic source. So this particular pathway worked very well for us. So again, not only considering how you're going to move your patients in your primary hub site, but how are you going to partner with your spoke sites that might be receiving patients with you? So who are your stakeholders? So we began with our stakeholders when we started this process. We said, who all needs to be involved in this? So you can see on the left, these are all of the individuals we identified. And then we really broke it down to who needs to be our bedside response team, and then just who needs to be our consultants. Who does not need to really come to the bedside, but we need you to engage in the process, and we need you to be a part of the stroke alert when we ask you to be. And so we have our PICU, or emergency medicine physician in charge nurses, our anesthesia team. We do bring our adult stroke coordinator if they're unavailable. We actually bring our AST nurse, which is our acute stroke nurse on the adult side 100% of the time. Then somebody from my team on the neurovascular neurosurgery APC team will respond to 100% of PEDS stroke alerts. And then we bring child life services and our chaplain to every response PEDS code. So in consultant, and again, the consulting comes through on join. So our consultants can communicate directly with the bedside response team on any recommendations and review of imaging. And that's our PEDS neurology, our neuroendovascular, our neurosurgery colleagues, neuroradiology, and our pharmacists. So we don't bring everybody to the bedside, but we have a collaboration mechanism for 100% of our workflows. So then we created the workflow and algorithm. And of course, this is a busy slide. Happy to always share anything with you guys, but this is our pediatric stroke algorithm that we built out. So we did determine our inclusion and exclusion criteria for actually calling the PEDS stroke alert. This is what you need to have in place to say, is it this? Yes, 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 or one yes is all it takes from us, and you should be calling a PEDS stroke alert. That's it. It's as simple as that. Consider the neurological assessment tool, design your algorithm, establish some time goals, and don't overthink it. Make it simple. If you have nothing in place, what's your door to needle time? What's your door to consult time? Whatever it is, make that simple. Right now, there's no benchmarks to guide us on this in PEDS. So, kind of it's the world's your oyster and choosing what data you want to chase on this right now. Create your communication channel. So again, we use pagers and we use our join chat as our primary form of communication. This is our criteria for actually initiating the stroke alert itself. So it's very simple. You have to be less than 18 years of age to be in a PEDS stroke alert. You have to have signs and symptoms consistent with acute focal neurological deficit, and you have to have a positive screen with at least one yes on our stroke screening question. And that is administered by the nurses at the bedside that are part of that bedside response team. We use BFAST, and BFAST, in addition, at the very end, we really try to delineate some of the time points. Did the problem begin or get worse suddenly? And has the problem been present for less than 4 hours? Yes to any of those screens is a positive inclusion, and you launch a stroke alert. Exclusion, we don't include any neonates in our process. We then also created order sets. So we did create both a specific panel or order set, I should say, for thrombolytic therapy for our PEDS patients. And we also created a workup specific to PEDS. We really kind of as we looked at this, we felt like the workup looked very different for every one of our pediatric patients. We wanted to standardize that. What's the imaging? What are the most common labs? What are the consultants we need to get on board? What's some of the timeframes of things? So we created a workup panel. And then as we started to take more of our kids to the interventional lab, right now what we have pending is we've created a neuroendovascular post-procedure order set. And that is very specific, again, to our pediatric kids and who we need to get involved in care of them during a procedural phase. So this is the neuroassessment tool, and this is, you guys are all familiar with NIH, I am sure, so not going to read through this. I really just share with you that you have to consider how you're going to alter your tool for a PEDS patient. So, you do have to, when we talk about read, describe, the picture, name the items and repeat after me, you want to make it a bit more simplified. We're not going to show them feathers and armchairs as pictures to name, but, they understand a clock and a skateboard, a pen, a baseball. So again, adjusting your tool to match the needs of your pediatric patients is important. Even understanding that as you talk to them about following commands, to ask them to open and close their fist, open and close their eyes. They may not be able to understand that command as well as an adult. So again, you might say something along the lines of, can you touch your nose? So giving them a very specific command that they would understand. So just keep in mind how you may need to alter your exam to fit your population. Educating your team and kind of the team design. So keeping in mind, as you put your stakeholders together, you've created your workflow and algorithm, you've created a pathway to launch the alert. You have to educate everybody on it, right? So nursing, your providers, your pharmacist, does everybody understand kind of who's coming to the table, what the expectation and roles and responsibilities are of each of those individuals is very important. Creating a pediatric stroke committee and having regular meetings. Again, this is where your pediatric leader champion is going to be running these committee meetings potentially. That's how we have it set up, is our pediatric neurointensivist is actually the leader of our committee groups, sets up the invites, leads the meetings, presents the data, reviews outliers with her team, and has been extremely beneficial. And of course, those meetings include our adult patient population and all of those that are responding to the alerts. Creating stroke sim labs, and then creation of an IV thrombolytic tip sheet. So this is what our tip sheet looks like. So again, talking about inclusion and exclusion specific to thrombolytic therapy. It's still a necessary item in our tool chest, right? But also talking about administration and dosing, talking about post-administration monitoring, frequency of assessments. Again, just kind of giving a very quick glance tip sheet, and then a review of those complications. So again, meant as an educational training tool in terms of management of bleeding, management of angioedema, those sorts of things. So data and evaluation. So you need to identify what data you really want to collect. And this, there's no pediatric measures as a standard around this. I would suggest you start with, do you have gaps in process? Like just starting there. What we identified is our biggest gap was we didn't have a process. We actually didn't have a pediatric stroke team. That was the first thing to address. We noticed that there was no identified stroke alert number. We weren't capturing stroke alerts. How were we even capturing that? So that was the first step. So looking at where you may have gaps, then we started to recognize, okay, once we got a process in place, it's taking us really long to get imaging. So that became our next focus. Is still our focus. It takes a long time to get PEDS imaging done. So really identifying where your gaps are, what are the outliers in your data is really where you choose to start your focus at. Creating a quality improvement plan is really the key to this. What data elements, how do you want to define them? Who's responsible for collecting them? Like any adult program, right? You have somebody in quality and data that's doing this for us in our adult programs. Your PEDS program should be no different, and they might cross over. That might be dependent on your resources at your hospital. So do you need FTE? Do you have somebody in place that can already be doing this? And then how do you want to report and share this? Again, having that pediatric committee is what's going to really allow you the forum to share data and to help people to be engaged in the process, to be engaged in the program, and to know where we're really excelling and doing well and where we're still not doing well in our pediatric stroke alert process as we're kind of rolling that out. And then you want to collect kind of a baseline, right? So where are you starting at? Where's your starting point? And then using that as sort of the basis of your comparison as you move forward and how you're going to evaluate your program, how you're going to evaluate your outcomes. So these were some of our stroke alert volumes. And so when I say we didn't have a stroke alert capture, you can see in 2018, we had 1 stroke alert. So that tells you about what kind of process we had in place. There was actually only 1 pediatric stroke alert that was called in all of the year of 2018. Well, we know for sure that's just, there were more pediatric strokes in our hospital than that, which tells us, okay, we did not capture this. We have no process in place by which we're capturing it. What are we going to do about it? You can see that we then in 2019 began to have these discussions. We put our team together and we started to really get our act together on how we were going to respond to our PEDS patients. So in 2019, and of course, we're doing all this through COVID, which, you know, that didn't cause any challenge at all. But in 2019, we actually had 9 stroke alerts. 2020, 15, 2021, we had 15. In 2022, and this data is through July, we've already had 24. And so we're on target to probably be at about 40 to 50 stroke alerts for this year in our pediatric stroke population, which I'm very happy seems to be really probably on target with where we should be in this population. So then when we look at percent of imaging positive for stroke, and we think about that number I just gave you. So that first year, we were dead on. That 1 patient we called a stroke alert process, well, we were correct. Good job, guys. We were 100% positive, and knowing that 1 patient we called a stroke alert on was really having a stroke. We know we're failing miserably if we're at this number because it means we're missing a lot, right? In our adult population, our overcall is big, right? In most adult population stroke alerts, we know that we are probably percent positive imaging for stroke at about, depending on your program, 30 to 50%. And I would argue if it's even at 50%, you're probably not calling it enough, right? We might be missing people. So we know that we're going to be, you know, our sweet spot might be at around that 25 to 40% in percent imaging positive and where we want to be with our pediatric stroke population. So to date, we're probably at an average of about 25% in the last 3 years. So we're getting there. So we know we're probably actually calling stroke alerts on the right patients at this point in our hospital when they arrive to us. So to date this year, we're at about a 24% positive imaging rate. Clinical presentation, as I said at the beginning, they present differently. You know, we can see here that definitely a good portion of them presented with focal weakness and facial droopiness, and 9% headaches. So they do have these other array of symptoms: headaches, seizures, some with speech, visual changes, and then this, you know, 8% bucket of other. You know, what does that mean? And there was a lot of things that actually went into that. So I would say just keep in mind that they don't present the same way for everybody. So when you see that patient, have that low threshold for your pediatric group to pull the trigger, to get the team to the bedside and do the workup that we've kind of laid out in our algorithm to get done for them. Imaging was a big issue for us, remains a big issue for us. So in 2020, we had our door to start imaging at about 105 minutes and didn't have it resulted for almost 3 hours. Okay. So as we can all think about this, do we really want to wait 3 hours for our kids? If this was my child or your child or your niece or your nephew or your grandchild, your neighbor, do you want them waiting 3 hours to have a stroke diagnosis on imaging? And of course we don't. We needed to find a way to improve this. One of the ways we've done this is we've got anesthesia now in our bedside response. We worked neurorads into our stakeholders committee. We have pediatric neurology and our neuroendovascular guys engaged on our communication channel early on. And we've got buy-in to move away from 100% MRI imaging to children over 12 years of age, and as appropriate and at the discretion of our providers, will get CT, CTA. Not all of our patients 100% will just have MRI. That is definitely a change for us. We're monitoring that closely, but you can see our door to imaging timeline has significantly improved from 2021 to current date in 2022. So we're making gains. But again, evaluating the gaps as you engage in your process and drilling it down is extremely important. So I'm just going to end on one of our successful cases. This, of course, is my partner in crime, Dr. Lopez. And with the approval of all the patients I've shown you in my slide deck, we've worked so closely with them. And this adorable little 8-year-old came to us as a stroke alert. She arrived actually EMS when her dad, she has a history of Downs. One of our hospitals has one of the largest Down syndrome program in the Midwest. And so we see a lot of Down's patients, and she came out of the bathroom and he noted that she he was more worried about her being incontinent, which was abnormal for her. So again, talk about abnormal clinical presentation. He was more worried about that, thought she might have a little right facial droop, but was actually more concerned about her incontinence than anything. And that was what prompted this. And so by the time she did get to us, you can see she's got a pretty significant medical history. She was on daily aspirin for her other comorbidities and her multiple cardiac surgeries. Her NIH was actually 30 when she arrived to us in the ER. The neuro IR team was notified via our joint chat, but differentials on our emergency medicine pediatric groups with seizure and stroke. A hyperacute MR protocol was ordered on her, and we do have a very particular hyperacute MR protocol in place, and we will bypass it and go to CT if we cannot get our pediatric patients in for hyperacute protocols, again, at the discretion of our providing team. She was taken emergently to our angio lab where we did a left MCA thrombectomy. We were able to successfully recanalize her, and she was discharged to acute inpatient rehab with really 40% at the time, and actually should have modified that. She was eating through that Dobhoff tube, or she was getting feeds through the Dobhoff tube, which is now out. She no longer has this right hemiparesis. It's almost 100% resolved, and she is back to her baseline, really doing quite well. So that's what we've did in our program in addressing our pediatric population, and I'm happy to take any questions.
Any questions? Thank you, Giffen.
Email if you want any.
Thanks, Kiffin. That was awesome. I know we have a couple of emergency room folks in the room, and a couple, maybe a pediatric person or two. So we do have a pediatric team at Wolfson that does collect some of that data already. So, moving in the right direction there. So it's my honor to present Merle Sapin, who I think most of you know. Merle is our lead endovascular neurosurgery advanced practice nurse practitioner. She's a DNP, and she's going to talk to us today about preventing post-op complications in craniotomy patients. So Merle.